Welcome back to the Deep Dives, where we cut through the noise and get straight to the insights that truly matter. Today, we're embarking on a crucial journey into problems related to movement and coordination, pulling key concepts from Section 12 of your Lewis's Medical Surgical Nursing textbook. Think of this as your integrated blueprint, connecting the intricate workings of the nervous and musculoskeletal systems directly to your future nursing practice.
Exactly. And what we're aiming to do is help you see beyond just individual chapters. Our mission today really is to identify the overarching patterns, those shared pathophysiologies, essential assessment strategies, and priority interventions. Things that will not only solidify your understanding, but, more importantly, empower you to deliver truly exceptional patient-centered care.
Right. We'll be looking for those pivotal aha moments, bridging that gap between textbook knowledge and, well, real-world clinical scenarios. It's about seeing the nervous system not just as a collection of parts, but as a dynamic, interconnected whole. So let's unpack how this integrated perspective translates into effective nursing care. All right, let's lay the groundwork. Our entire capacity for movement, sensation, thought. It originates from one incredible network, the nervous system. What are the absolute fundamentals we need to grasp here?
Well, at its core, it's about the neuron. That's the main functional unit. These cells are remarkable for their excitability, their ability to conduct impulses, and to influence other cells. Each neuron has a cell body, then dendrites to receive impulses, and an axon to transmit them. And for efficient, rapid communication, many axons are myelinated. This allows impulses to literally sort of hop along.
Saltatory conduction.
Exactly, saltatory conduction. It makes signal transmission incredibly fast, like electricity jumping across insulators on a wire. Super efficient.
And this vast network is organized into major divisions, right? The central nervous system, the brain and spinal cord.
Yep, the CNS, and the peripheral nervous system, which extends throughout the body.
Got it.
That's right. And within the peripheral nervous system, the autonomic nervous system, the ANS, often plays a huge role in the conditions we'll discuss later. And protecting these vital structures are the meninges, the dura, arachnoid, and pia mater.
Like layers of security.
Precisely. Layers of security around the brain and spinal cord. Also critical is the blood-brain barrier, a highly selective barrier safeguarding the brain from many substances circulating in the blood.
Speaking of the brain supply lines, the circle of Willis sounds impressive for cerebral blood flow, but I've heard it's not always perfectly formed in everyone. What's the clinical significance of that variability?
Yeah, it's a fascinating point. The circle of Willis is designed as an anastomostic circle, fed by the internal carotid and vertebral arteries. The idea is to ensure a continuous blood supply to the brain, even if one vessel is compromised.
A backup system.
Kind of, but anatomical studies show its formation varies greatly among individuals, and it's often incomplete. This means some people lack that full protective redundancy, making them potentially more vulnerable to ischemia if a primary artery gets blocked. So this variability highlights why understanding a patient's individual cerebral vascular anatomy can be crucial, especially when you're thinking about risk factors.
That makes sense. And how do these foundational elements, the neurons and their intricate systems, change as we age? What does that mean for our nursing assessments?
Well, with age, we tend to see gradual neuron loss in certain brain areas, a widening of the ventricles, and reduced cerebral blood flow and CSF production. In the peripheral nerves, myelin degenerates, which decreases nerve conduction velocity.
So things slow down a bit.
Right. Clinically, this can manifest as impaired temperature regulation, maybe a higher risk for orthostatic hypotension, and slower reflexes. As nurses, our primary task then is to establish a thorough baseline neurologic assessment for each patient, because what's normal aging for one person might actually be an early sign of pathology for another. You really need to know they're normal to spot those changes effectively.
Okay, so we've explored the healthy, functioning system. Now let's pivot to when this intricate system is under immense pressure or facing direct injury. This is where it gets really critical. Increased intracranial pressure, head trauma, and infections.
Indeed. Increased ICP, or intracranial pressure, is a life-threatening emergency. Think of the skull as a rigid box. Inside, you've got brain tissue, blood, and cerebrospinal fluid, or CSF. The Monro-Kelly hypothesis states that if the volume of one component increases, another must decrease, or that pressure inside the box will rise.
And that rising pressure is bad news for the brain.
Very bad news. When ICP rises significantly, it directly reduces cerebral perfusion pressure CPP, which is absolutely vital for brain tissue survival. A CPP below about 50 millimole Hg likely means ischemia and neuron death.
And for nurses, recognizing the warning signs is paramount. I'm thinking of the classic Cushing's triad.
Absolutely. Cushing's triad, that's systolic hypotension with a widening pulse pressure, bradycardia, and irregular respirations, is a major medical emergency. It signals impending brainstem compression and is a critical, though often late, sign of severely increased ICP. Recognizing this triad demands immediate intervention.
Okay. Now, with head trauma, our immediate go-to for assessment is off of the Glasgow Coma Scale, the GCS.
Correct. The GCS assesses eye-opening, verbal response, and motor response.
Oh.
It gives us a rapid, standardized way to evaluate neurologic status. A score of 8 or less typically indicates coma. But remember, the GCS isn't just a static number. It's really about trending changes.
So drop-in score is a warning sign.
A huge warning sign. Even a slight drop in a patient's GCS score, even if it's still above 8, can be a red flag. We also categorize head injuries as diffuse, like concussions or diffuse axonal injury, or focal, like a contusion or a hematoma. A key one to recognize is an epidural hematoma. This is a neurosurgical emergency, often arterial bleeding between the dura and the skull. It can develop rapidly, sometimes with that brief lucid interval before a sudden deterioration.
Right, the lucid interval. And what if we encounter clear drainage from the nose or ear after a head injury?
That could be CSF rhinorrhea or otorrhea. It's clear or maybe slightly yellow drainage that tests positive for glucose. This indicates a meningeal tear and basically an open pathway for infection into the brain.
So what's the immediate action?
You must notify the healthcare provider immediately. And critically, never attempt to block the drainage with a dressing inside the cavity or perform nasotracheal suctioning. That significantly increases the risk of meningitis.
Okay, crucial point. Shifting gears slightly to infections, what are the critical red flags for bacterial meningitis?
High fever, severe headache, neck stiffness, we call that neutral rigidity seizures, and changes in mental status are all hallmarks. For bacterial meningitis, rapid administration of 5E antibiotics is absolutely critical to maintain therapeutic levels and improve outcomes.
And managing the fever.
Yes, vigorous management of fever is essential. It helps prevent cerebral edema and seizures. Patients often find comfort in a curled-up position with their head slightly extended, and a darkened, quiet room really helps with the photophobia, the light sensitivity.
Okay. From acute pressure and trauma, let's explore another major threat to movement and coordination: stroke. The term brain attack really underscores the urgency, doesn't it?
It absolutely does. Time is brain isn't just the slogan, it's a clinical imperative. Every minute that cerebral blood flow is interrupted, millions of neurons die. That's why the FAST acronym is so important for public awareness.
Remind us what FAST stands for.
Sure. Face drooping, arm weakness, speech difficulty, time to call 911. Simple, but potentially life-saving.
And for us nursing students, identifying risk factors for prevention is key, isn't it?
Absolutely key. We classify them as non-modifiable, things like age, gender, ethnicity, and modifiable, which are the ones we can target. Things like hypertension, diabetes, smoking, atrial fibrillation. And it's crucial to educate patients that transient ischemic attacks, or TIAs, are like mini-strokes. They're caused by a temporary blockage of blood flow.
So they're warning signs.
Critical warning signs of an impending stroke. They demand immediate medical evaluation, even if the symptoms resolve quickly. Don't ignore a TIA.
We primarily see two main types of stroke. How do they differ, and what does that mean for immediate treatment?
Good question. The majority are ischemic strokes, caused by inadequate blood flow due to a clot. This can be thrombotic, where a clot develops in a narrowed vessel right there in the brain, or embolic, where a clot travels from somewhere else, like the heart in atrial fibrillation. Then you have hemorrhagic strokes, which are less common but often more severe. These are caused by bleeding into the brain, maybe from a ruptured aneurysm or uncontrolled hypertension.
And that distinction is vital for treatment. Right.
Absolutely vital. For ischemic strokes, the window for TPA, or tissue plasminogen activator, the clotbuster drug, is incredibly tight. Ideally within 3 to 4.5 hours of symptom onset, maybe up to 6 hours for intra-arterial delivery in some cases. But for hemorrhagic stroke, anticoagulants like TPA are strictly contraindicated. The focus shifts entirely to managing blood pressure aggressively and preventing seizures.
And from a nursing assessment perspective, Those initial symptoms can really point us towards which part of the brain is affected, can't they?
They absolutely can. It's like detective work. If a patient presents with sudden weakness on their right side and has trouble speaking, you're immediately thinking about damage to the left hemisphere, which often controls language centers.
Okay.
Conversely, if you see left-sided paralysis and maybe spatial perceptual deficits, difficulty judging distances, for example, that points towards right brain damage, these patterns are fundamental to your initial assessment and subsequent care planning.
A huge challenge for stroke patients and their families is communication, especially with aphasia.
It's a profound impact. Aphasia, the language disorder, can manifest in different ways. There's receptive aphasia, where comprehension is lost, they can't understand what you're saying. Expressive aphasia, where the patient struggles to produce language, find the right words. Or global aphasia, which is a total inability to communicate. It's devastating.
So as nurses, how do we help?
Our role is crucial in facilitating communication. Use simple, short sentences. Use visual cues, gestures, pictures, and importantly, allow ample time for the patient to process information and respond. Never assume they don't understand just because they can't speak clearly. Patience is key.
Okay, after the acute phase, what are the top nursing priorities for stroke recovery?
Post-acutely, nursing care becomes really multifaceted. Respiratory support is ongoing, vigilantly assessing airway patency, and critically, preventing aspiration. You need to frequently check the gag reflex before allowing anything by mouth.
Skin integrity too, right?
Absolutely. Maintaining skin integrity through regular repositioning is vital. And promoting musculoskeletal function through proper positioning to prevent things like contractures and foot drop. Early mobilization, as tolerated, is always encouraged. The whole nursing process for a stroke patient revolves around maximizing their functional abilities and preventing those secondary complications.
Now let's transition into the realm of chronic neurological conditions. This is where long-term management and quality of life become really central. We'll cover quite a spectrum here, from persistent headaches to progressive degenerative diseases.
Yeah, and what's truly fascinating here is the sheer diversity of symptoms that can arise, even from diseases that might seem similar initially. Take headaches, for example. We need to differentiate. There's tension type, which is often bilateral, feels like a pressure or tightening, usually no nausea.
The common stress headache.
Pretty much. Then you have migraines, typically unilateral throbbing pain, often with photophobia, phonophobia, and nausea or vomiting, much more debilitating. And then cluster headaches. These are excruciatingly severe, usually unilateral, radiating from the eye, often with autonomic symptoms like tearing or nasal congestion on that side. They come in clusters, hence the name.
And there's a crucial safety alert for headaches we should remember.
Absolutely. Any severe headache accompanied by a stiff neck, confusion, sudden vomiting, or a rash requires emergent evaluation. Don't wait.
Because it could be something serious.
Exactly. Could be meningitis, could be a hemorrhage, needs immediate attention.
Okay. Moving on to seizure disorders, what are the key phases nurses need to be aware of?
Right. Seizures typically occur in 4 phases. There might be a prodromal phase, with vague behavior changes hours or even days before. Then an oral phase, which is a sensory warning right before the seizure hits, maybe a smell, a visual disturbance. The ictal phase is the actual seizure activity itself. And finally, the postictal phase is the recovery period afterward, where the patient might be confused, drowsy, or have muscle soreness.
And during the ictal phase, the seizure itself, what are the nursing priorities?
Priorities are clear. Maintain a patent airway, turn them to the side if possible. Protect the patient's head from injury. Loosen any restrictive clothing around the neck. And crucially, never restrain a patient during a seizure and never place anything in their mouth. That's an old myth and can cause serious injury.
Got it. Let's discuss multiple sclerosis, or MS. That's an autoimmune condition, right?
Yes. MS is an autoimmune disease where the body's own immune system attacks the myelin sheath insulating nerve fibers in the central nervous system. This leads to chronic inflammation, demyelination, and scarring, or gliosis, which forms plaques. This disrupts nerve signals, causing a really wide array of symptoms, motor, sensory, cognitive, that often wax and wane. Patients have periods of remission and then exacerbation or relapse.
And nurses need to know about triggers.
Yes, understanding triggers is important for patient education. Things like infection, physical trauma, significant stress, and even overheating can worsen symptoms or trigger a relapse. Also, bladder dysfunction, either spastic, causing urgency and frequency, or flaccid, causing retention, is a very common and challenging symptom in MS that requires careful assessment and management strategies.
Okay. And Parkinson's disease, known for its characteristic movement challenges.
Parkinson's involves the progressive degeneration of dopamine-producing neurons, mainly in an area of the midbrain called the substantia nigra. Dopamine is crucial for smooth, controlled movement. The classic manifestations, the TRIA acronym helps. Tremor, often a pill-rolling tremor at rest. Rigidity, like stiffness, sometimes cogwheel rigidity with jerky movements. Akinesia or bradykinesia, meaning absence or slowness of movement. And postural instability, leading to that characteristic shuffling gait and balance problems.
And since there's no cure.
Right. Since there's no cure, nursing management focuses heavily on symptom control and maintaining quality of life for as long as possible. This includes encouraging regular exercise, ensuring a well-balanced diet, and you need to be mindful of protein intake timing with levodopa medication to optimize its absorption, and providing ample time for activities of daily living, ADLs, always prioritizing safety because of their impaired balance and shuffling gait. Fall risk is high.
Myasthenia gravis sounds like another condition causing fluctuating muscle weakness.
It is. MG is an autoimmune disease affecting the neuromuscular junction, where nerve signals trigger muscle contraction. Antibodies block or destroy acetylcholine receptors. This causes fluctuating skeletal muscle weakness that often affects the ocular muscles first, leading to ptosis, or drooping eyelids, and diplopia, double vision. It can also affect muscles for chewing, swallowing, speaking, and breathing. Characteristically, muscles are strongest in the morning and weaken with activity throughout the day.
And there's a crisis potential here, too.
Yes, a myasthenic crisis is a critical concern. It's an acute exacerbation of muscle weakness, potentially leading to respiratory failure and aspiration because the muscles of breathing and swallowing become too weak. Prompt respiratory assessment is an absolute priority in MG patients.
Okay, finally in this group, a pair of conditions that often cause confusion, especially in older adults. Alzheimer's disease and delirium. How do we as nurses differentiate between the gradual decline of AD and the acute onset of delirium? That seems like a really important distinction.
It really is a key distinction and often missed. Alzheimer's disease involves progressive neuron death, along with the buildup of amyloid plaques and neurofibrillary tangles inside neurons. This leads to a gradual, irreversible cognitive decline over years. It's insidious. Delirium, in stark contrast, is an acute, fluctuating disturbance in attention and cognition. It has a sudden onset, usually hours or days, and it's often caused by an underlying medical condition, medication side effect, or infection. It's typically reversible if the cause is treated.
So one is slow and progressive, the other is sudden and fluctuating.
Exactly. And for delirium, the mnemonic DELIRUM is a great tool for remembering potential causes you need to investigate.
Can you run through that quickly?
Sure. Dementia, dehydration, electrolyte imbalances, emotional stress, lung, liver, heart, kidney, brain issues like stroke, infection, ICU environment, RX drugs, especially new ones, or polypharmacy, injury, immobility, untreated pain, unfamiliar environment, and metabolic disorders like thyroid issues or vitamin deficiencies.
That's comprehensive. So nursing interventions for delirium focus on.
Focus on reorientation, frequent, calm reminders of person, place, time, creating a calm, well-lit environment, and critically, identifying and addressing those underlying causes from the mnemonic, treat the infection, correct the electrolytes, manage the pain, and with both AD and delirium, caregiver support is absolutely paramount. They often bear a significant physical and emotional burden.
So teaching is key.
Vital. Patient and caregiver education on managing difficult behavior safely, ensuring safety at home, particularly fall prevention, and encouraging discussions about advanced directives early in the course of AD are all vital aspects of compassionate nursing care.
All right, moving from the brain and central control down to the body's framework, let's explore the spinal cord and the entire musculoskeletal system. This is where movement and coordination, or the lack thereof, really become tangible.
Yeah, spinal cord injury, or SCI, immediately impacts movement and coordination, often with profound and frankly life-altering consequences. We classify these injuries by the mechanism of trauma flexion rotation as often the most unstable. Also by the level of injury cervical, thoracic, lumbar, or sacral, which dictates whether someone has tetraplegia, affecting all four limbs, or paraplegia, affecting the lower limbs. And also by the degree of injury, whether it's complete, meaning total loss of function below the injury, or incomplete, where some function remains.
And for higher-level SCIs, say T6 or above, there's a specific life-threatening complication we absolutely need to be on high alert for: autonomic dysreflexia.
This is a critical one. You have to know this. Autonomic dysreflexia is a medical emergency. It's triggered by some kind of noxious stimuli below the level of the spinal cord injury, most commonly a distended bladder or impacted bowel, but even tight clothing or skin irritation can do it. The body overreacts with a sudden, massive sympathetic response above the injury level. You see sudden, severe hypertension, throbbing headache, profuse sweating above the injury, but maybe pale, cool skin below, and often bradycardia, a slow heart rate.
So what's the very first nursing action?
First action. Elevate the head of the bed immediately to 45 degrees or sit the patient fully upright. This helps lower the blood pressure via gravity. Then you immediately need to find and remove the cause. Check the bladder catheter for kinks, assess for bowel impaction, loosen clothing. Fast action is crucial.
Wow, okay. Other key SCI considerations.
Definitely. Managing neurogenic bladder and bowel, the loss of voluntary control, is a huge long-term challenge requiring consistent programs. Providing meticulous care for halo vests if used for cervical stabilization, especially pin site care to prevent infection, and always anticipating respiratory complications, especially with high cervical injuries like C4 or above, which can affect the phrenic nerve controlling the diaphragm.
Okay, zooming out now from the spinal cord to the entire musculoskeletal system, bones, muscles, joints. What are the key elements of a thorough nursing assessment here?
Well, we need to appreciate the basic structures. Cortical, dense bone versus cancellous, spongy bone, the different joint types like hinge joints in the elbow or ball and socket joints in the hip, and how muscles contract isometric, isotonic. And importantly, knowing the typical age-related changes like decreased bone density leading to osteoporosis risk and decreased muscle mass, sarcopenia. This helps you distinguish normal aging from actual pathology.
So the assessment involves.
Your assessment should include inspecting posture and gait, how they stand and walk, palpating joints and muscles for tenderness, swelling, or crepitation, that grating sound, evaluating both active range of motion, what the patient can do themselves, and passive range of motion, what you can move for them, often using a goniometer to measure angles. And grading muscle strength, usually on a 0 to 5 scale, where 5 out of 5 is normal strength against full resistance.
When trauma strikes this system, things like soft tissue injuries and fractures are really common. What are the immediate priorities?
For soft tissue injuries like sprains, which involve ligaments, and strains involving muscles or tendons, remember the acronym REC. Rest, ice, compression, and elevation. Helps control swelling and pain. For fractures, bone breaks, healing is a process that progresses through stages, starting with the formation of a fracture hematoma, a blood clot at the site.
And there's a major complication we need to watch for with fractures, especially in limbs.
Yes, a critical complication is compartment syndrome. This happens when there's increased pressure within a confined anatomical space, like a muscle compartment wrapped in fascia. This pressure compresses nerves and blood vessels, potentially leading to irreversible damage if not treated quickly.
How do we spot it?
Look for the 6 PS, pain that's out of proportion to the injury or unrelieved by typical pain meds, paresthesia, numbness, or tingling, pallor pale, cool skin, pulselessness diminished or absent pulse distal to the injury, paralysis, loss of motor function, and poikilothermia, the limb feels cool compared to the other side. Your neurovascular assessment, checking circulation, sensation, and movement distal to the injury is absolutely paramount. Any sign of the 6 Ps demands immediate notification of the provider. It's an emergency.
I also recall fat embolism syndrome being mentioned with long bone fractures.
Indeed, FES is another serious complication, particularly associated with fractures of long bones like the femur or pelvic fractures or major trauma. Fat globules are released from the bone marrow into the bloodstream and can travel to the lungs, brain, and skin. It typically presents with respiratory distress hypoxia, tachypnea, altered mental status, and a characteristic petechial rash, often on the chest, axillae, and neck. Needs urgent supportive care.
Okay. And thinking about post-op care, particularly after hip fracture repair or hip replacement, what are the key precautions?
Good point. Diligent attention is needed to prevent dislocation of the prosthesis, especially after a posterior surgical approach, which is common. You must teach the patient and enforce precautions like avoiding hip flexion beyond 90 degrees, so no low chairs or bending way over, avoiding adduction, meaning crossing the legs or ankles, and avoiding internal rotation of the hip, turning the foot inward. These are critical patient teaching points to prevent the hip popping out.
Finally, let's briefly tackle some of the major chronic musculoskeletal conditions, from bone diseases to arthritis.
Okay, osteoporosis is huge, especially in older adults, particularly postmenopausal women. It's where bone resorption, the breakdown of old bone, outpaces bone deposition, the formation of new bone. This leads to fragile, porous bones that fracture easily, often in the hip, wrist, or spine. Spinal compression fractures can lead to that stooped posture, kyphosis. This really highlights why adequate calcium and vitamin D intake, weight-bearing exercise, and rigorous fall prevention strategies are so crucial.
And then arthritis, the two main types.
Right, we need to clearly differentiate osteoarthritis, or OA, from rheumatoid arthritis. RAOA is generally considered a non-inflammatory degenerative wear and tear disease. Cartilage breaks down, bone spurs can form. Pain typically gets worse with activity and better with rest. Morning stiffness is common, but usually resolves within about 30 minutes. RA, in contrast, is a chronic, systemic, autoimmune inflammatory disease. The body attacks the synovial lining of joints, leading to inflammation, pain, swelling, and potentially significant joint destruction and deformities like ulnar drift in the hands. Stiffness in RA is often worse in the morning and can last for hours. It also has systemic manifestations, fatigue, fever, maybe effects on other organs.
So management is different too.
Very different. For RA, managing the underlying inflammation is key, often using disease-modifying anti-rheumatic drugs or DMARDs and biologic response modifiers, BRMs. Nursing focuses on pain management, balancing rest and activity to protect joints but maintain function, and teaching joint protection strategies. And then briefly, gout. That's another type of inflammatory arthritis. Yes, gout is caused by the accumulation of uric acid crystals in the joints, leading to sudden, severe attacks of inflammation, redness, swelling, and intense pain. It most commonly affects the great toe, a condition called podagra. Triggers often include things like alcohol, especially beer, certain foods high in purines, and sometimes trauma or stress. Management involves medications to lower uric acid levels and treat acute attacks. So, across all these chronic conditions, osteoporosis, OA, RA, gout patient education, meticulous pain management strategies, promoting safe mobility within their limits, and preventing complications are really the constant vital themes in your nursing care plan.
Wow, that truly was an insightful deep dive, a real whirlwind tour through the fascinating and critical world of movement and coordination. From that tiny neuron all the way to complex fractures and chronic joint disease, it's just abundantly clear how interconnected everything really is.
Absolutely. And if we connect this back to the bigger picture for you as nursing students, remember that the body is like a symphony. A problem in one area, whether it's a neuron misfiring, a bone weakening, or a joint inflaming, can profoundly disrupt the entire composition. Your role, fundamentally, is to identify those disruptions, apply your critical thinking skills to uncover the underlying why, and then intervene effectively and compassionately. It really means not just memorizing isolated facts, but truly understanding the patterns, anticipating potential risks before they happen, and prioritizing care based on that integrated understanding.
And that's really what being well-informed is all about, isn't it? Taking that shortcut maybe to understanding the why behind the what. So you're not just reacting to problems, but you're truly anticipating and leading patient care.
Which leads to an important question for you to consider as you move forward. How will you leverage this understanding of these interconnected systems? How will you use it to anticipate your patient's needs, maybe even before they fully manifest, in your future practice? Because that ability to predict, to prevent, to see the connections, that's really a hallmark of an exceptional nurse.
Keep those questions coming. Keep digging into your sources like Lewis's and keep connecting those dots. You're going to make incredible nurses. Thank you so much for joining us on this deep dive. We'll catch you on the next one.